Hello, my name is Melanie Campos and I'm going to talk about TARGT gene therapy platform for correction of anemia in end-stage renal disease. Definition: anemia, an end-stage kidney disease, also known as kidney failure, often go hand in hand. Most people with kidney failure who are on dialysis have anemia. Kidney transplant patients are also increased risk for anemia. Healthy kidneys help send signals to your bones to make red blood cells. So, if your kidney fail, they may not be able to help your body make the red blood cells it needs.
Welcome back to Medicosis Perfectionalis. Let's continue our talk on normocytic anemia, and today's topic will be anemia in chronic kidney disease. In the good old days, we used to call it kidney failure or chronic kidney failure. Now we call it chronic kidney disease because we do not like failure. Symptoms of anemia are the exact same thing: tired, pale, headache, lazy, dizzy, short of breath on exertion, angina. The signs will include stuff like murmur due to a hyperdynamic circulation and so forth. Here is your hematopoiesis slide. We start with stem cells and we go to RBCs. So in anemia, we're having problem producing enough RBCs. All of these steps need something called EPO, erythropoietin, from your friend, the kidney. That's fine. And as you are well aware that MCV determine if the anemia is microcytic, normocytic, or macrocytic. Anemia related to chronic kidney disease is normocytic, MCV 80 to 100 femtoliters. Okay, but first I would like to answer a question of the previous video. In the last video on aplastic anemia, there was a question. The answer to the question will be D, phenytoin. Now, back to anemia in chronic kidney disease. As you know, the normocytic anemia, where the MCV is 80 to 100, has three main causes: blood loss, underproduction, overdestruction. Of course, the blood loss has to be acute. Underproduction has many causes.
Applications in medicine. Patients who have had a kidney transplant are at higher risk for anemia. Anemia in kidney transplant patients is caused by having less erythropoietin than normal, less iron than normal, immunosuppressive drugs. This is because the new kidney betrays some time before it begins to produce enough EPO, and because the patient's iron level are low from blood loss. Over time, the risk of anemia decreases in patients who have a kidney transplant as long as their new kidney remains healthy.
Hello, in this video we're going to talk about chronic kidney failure. It can also be referred to as chronic kidney disease, but failure, I guess, is the end stage. And chronic kidney failure is essentially where you have loss, an irreversible loss of the nephrons. And the nephrons are the functional units of your kidneys. And this can result in a toxic state, such as uremia. And we'll learn about that in this video. So here, before we go into chronic kidney failure, let's just recap the anatomy slightly. So here I'm drawing the kidneys. The kidneys connects the ureter to the bladder. Bladder stores urine, ready for micturition. And here we have the inferior vena cava and the descending aorta, which has vessels coming in and out from the kidneys. Okay, so there are many causes of chronic kidney failure. And these include acute kidney injury or acute kidney failure, hypertension, diabetes, and other kidney diseases. Other kidney diseases includes polycystic kidney disease. So all of this can lead to an irreversible loss of nephron. which is chronic kidney failure or disease. So let us look at each of these causes of chronic kidney failure in a bit more detail. Let's begin by looking at acute kidney failure or acute renal failure. It's the same thing. So acute kidney failure can lead to, chronic kidney failure. Acute kidney failure, unlike chronic kidney failure, is reversible. And there are many causes of acute renal failure in itself. One way to categorize it is into pre-renal causes, intra-renal causes, and post-renal causes. So pre-renal cause includes renal artery stenosis, heart failure, and hemorrhage, all which leads to acute kidney failure. And then you
Pros and cons. The anemia associated with CKD is as usually normocytic and normochronic and without iron deficient ferritin, more than 100 nanograms milliliter, and transferrin saturation index, more than 20%. If not, other causes of anemia should be suspected. It should be remembered that the diagnosis of anemia or renal cause is a diagnosis of exclusion, that is, when patient presents CKD and anemia and other causes have been excluded.
Let me take a different tack here. We have two silos. One is chronic kidney disease, and one is end-stage renal disease. Is the treatment of anemia different for both of those or each of those silos?
Well, for dialysis patients, it's virtually everybody gets treated. In a given year, almost everybody will get some doses of EPO, and in a given month, 90% of them are getting EPO or a similar product. Even IV iron. If there are hemodialysis patients over the course of a year, virtually everyone gets iron, and in any given quarter, about 80% of them are getting iron. So it's very few of them avoid the need for this. And so it's not really much discussion and not much variation how we treat. What we've really talked about is CKD, and that's dramatically different.
All right, so we have some trials. You alluded to the risks of these. The trials I know that come to mind are Choir, and another one is Treat. What do they show?
So Choir was published in 2006, and it took CKD 3 and 4 patients who were anemic and randomized them to one of two doses of apoetin, one being a dose adjustment to get the hemoglobin to about 11.3 and the other to 13.5. So the theory was that raising the hemoglobin to normal would reduce cardiovascular events and death. And so that was the primary outcome of the study. But as Dr. Pfeffer, who did the subsequent Treat trial, pointed out, in studies like Choir, where both arms get the drug always wins. So the drug in this case won, but it was the lower hemoglobin that had less cardiovascular events and death. This was the first major non-dialysis study to show significant harm from use of these drugs.
Issue in Ecuador. Chronic kidney failure is widely distributed in the world and has become a public health problem, mortality in 20 times more than in the population general. This supports the need for the clinical to diagnose the disease in the beginnings and optimize proper handling, avoiding and being able to delay damage to the medulla.
So anemia of chronic disease is the second most common cause of anemia in hospitalized patients. And it's a type of microcytic anemia. Microcytic anemia. So that tells us that anemia of chronic disease is somehow due to a problem in producing hemoglobin, because we know that all microcytic anemias result from a problem in producing hemoglobin. So the second thing that's really important about this disease is that it's always related to some inflammatory condition. So that's to say that there must be some source of inflammation in the body for this disease to result. Now, anemia of chronic disease has absolutely everything to do with the molecule hepcidin, which is a polypeptide. It's just a fancy term for a chain of amino acids that's produced by the liver that serves as the body's major iron regulator. And by regulator, I mean that when the serum iron levels are low, when the body's iron levels are running low, there's a low production of hepcidin. But when the body's iron stores are running high, or when there's an excessive amount of iron in the body, the liver increases its hepcidin production. And it does this because the hepcidin then turns around and it decreases serum iron. And it does this, it decreases serum iron in a couple of different ways. And to understand how it decreases it, I guess we'd have to go back for a couple of seconds to understand iron physiology. So we talked about how iron is absorbed in the duodenum, but something we didn't mention is that at the base of these cells in the duodenum is this channel called ferroportin. And ferroportin is what allows the iron to go across these cells in the duodenum and be absorbed into the bloodstream. Now, hepcidin comes in and it blocks the ferroportin channels. And by doing so, it inhibits the absorption of iron from the gut. So that's the first way in which hepcidin acts to decrease serum iron levels. Now, I'm going to scroll down just a little. Okay, so secondly, let's take a look at the liver. And here's a blood vessel that has blood in it. And we know that blood has lots of red blood cells in it. And every 120 days or so, each one of these red blood cells is taken out of commission. It's retired. And it's degraded by cells in the liver called macrophages. So these red blood cells are broken down by the macrophages. And inside the red blood cells, we know we have lots of hemoglobin. And the hemoglobin has iron in its center. And the iron that is released from the degradation of the red blood cells isn't just thrown away. So let's talk about the treatment of iron deficiency anemia. And I'm really just going to abbreviate that IDA. So you'd imagine that with iron deficiency, it could be treated with supplementation of iron, and you'd be completely correct. You can treat iron deficiency anemia by giving a patient iron supplements. And there are a couple of different ways in which you can supplement iron. The first is by giving oral iron supplements. And a few things to keep in mind about oral iron supplements is, firstly, as we briefly talked about before, stomach acid plays a really important role in converting dietary iron into a form that's more readily absorbed by the duodenum. So a patient could help out the absorption of this oral iron if they were to take it alongside some acidic drink. For example, orange juice. That would help the absorption of the iron supplement. Secondly, oral iron can stain teeth black. And more importantly, it can cause black stools. And this is really important because upper gastrointestinal bleeding can also present with black stools. So if a patient has black stools, it's really important to go through their history and see if even remotely they've been taking any iron supplements that could account for the black stools, because upper gastrointestinal bleeding is a medical emergency.
Conclusion. All patients who underwent TARGT inclusion had an initial increase in plasma level of erythropoietin, and plasma level of hemoglobin remained above or within the desired range for most patients. The plasma level of the erythropoietin remained stable within the psychological range. Thanks.